Welcome students to Chapter 8, which is on the serious topic of suicide, and we're going to be looking at different factors related to suicide and how clinicians respond to this very sad situation in our society. Suicide is one of the leading causes of death in the world. Approximately 1 million people die every year, including more than 48,000 in our country alone. When we have economic recessions and depressions, for every 1% increase in unemployment, we have a corresponding increase in the national suicide rate. Suicide is not classified currently as a diagnosis in the DSM-5, but it is being proposed as a disorder for the upcoming revision of the DSM. So what is it? It is self-inflicted death, where someone is making intentional, direct, and conscious efforts to end one's life. And Schneidman looked at these sort of different approaches to suicide that people have. A death seeker is a person who is actively wanting to end their life. A death initiator is a person who believes that death is already underway, and so they're trying to help it along. For example, there may be a terminal illness or something of that nature. A death ignorer is a person who focuses on the idea that self-inflicted death doesn't necessarily mean that it's going to end their existence, so they have life after death. And then a death darer has mixed feelings, which are reflected in the way that they might try to take their life. Subintentional death is seen in suicidal behavior as well. So, for example, sometimes people take pills instead of doing something more serious like trying to shoot themselves. So the idea there is that they really don't want the suicide to be ultimately successful, but they're in a huge amount of psychological pain. This is also the case with non-suicidal self-injury. Many times, which is being studied for possible future DSM-5 revisions. This is where people cut themselves or do other self-injurious behaviors to alleviate psychic pain. Patterns and statistics of suicide rates vary from country to country along all different demographics. We do know that underreporting may exist. Interestingly, religious devoutness does tend to buffer rates of suicide. And we know that overall, across all of these demographic variables, the highest rates of suicide are for Native Americans, both male and female. There are plenty of opportunities for people to see modeled suicide on the internet these days. There are pro-suicide websites, live streaming suicides that take place, and we'll talk more about modeling in a bit, but this is something new that is contributing to the rate of suicide, especially among young people. Common triggers of suicide include stressful events, mood and thought changes, alcohol and other drug use, mental disorders, and modeling. In terms of stressful events and situations, immediate stressors might include loss of loved ones, loss of job or financial loss, natural disasters. Long-term stressors include things like social isolation, serious illness or injury, abusive or repressive environments, and occupational stress. Mood and thought changes that go along with suicide are certainly factors that we need to take a look at. Hopelessness is a very, very important factor. Sadness, anxiety, tension, and frustration, shame, all of those feelings can produce suicidal behavior. People sometimes talk about the term psych ache. And then there's dichotomous thinking patterns where it's like a black or white thought process, like if I don't get this job, everything will be lost in my life. So these dichotomous patterns of thinking can produce suicidal behavior as well. Alcohol and other drug use comes into play frequently, with 70% of suicide attempters drinking alcohol, and 1/4 of these people are legally intoxicated. Use of other kinds of drugs may have similar ties to suicide, particularly in teens and young adults. The majority of suicide attempters have a psychological disorder. Unipolar or bipolar depression is present 70% of the time, chronic alcoholism 20%, schizophrenia 10%, and the risk increases with multiple disorders being present. When Kurt Cobain committed suicide, we saw a lot of modeling that took place there, and especially among teens. So prominent celebrities committing suicide does produce a copycat effect. And so we need to look out for those things in society when they happen. So what are the underlying causes of suicide? Well, we have the psychodynamic view that suicide results from depression and anger at others that is redirected towards ourselves. We are introjecting a lost person. Later suicidal behaviors are thought to be related to childhood losses or parental rejection. And then Freud also said that there was this idea of a death instinct that we all have. Research, however, doesn't establish that suicidal people are dominated by intense anger. Durkheim's sociocultural view is more influential and research supported. Said that suicide probability is determined by attachment to social groups, such as family, religious institutions, and community. And there are different categories of suicide that he came up with, including egoistic. These people are isolated and alienated. They tend to be non-religious. Altruistic people are socially well-integrated people. And anomic people are inhabitants of personally unstable social environments and structures, so they have difficulty having a good meaning to life. And a major change in an individual's immediate surroundings can lead to this type of suicide. The interpersonal view of suicide says that people have these perceptions that are related to a desire to die by suicide, such as perceived being burdensome to another, or having thwarted belongingness and not being able to connect, and then the psychological ability to carry out suicide being acquired. Hopelessness helps to determine if the characteristics will lead to suicide in this model. In the biological view, early twin studies point to a genetic predisposition for people to have suicidal behavior. Brain development research looks at low serotonin activity and abnormalities in the depression-related brain circuits that contribute to suicide. Both aid in production of aggressive feelings and impulsive behavior. There are also key psychosocial factors that we've talked about. In terms of age range, starting in the teens, we see a spike in suicidal behavior that peaks at mid-age, 45 to 64, declines at 65, but then goes almost as high as the peak at the age bracket of 75 and over. In terms of adolescence, suicidal actions become much more common after the age of 13. About 8 in every 100,000 teenagers die by suicide yearly. 17% have persistent suicidal thoughts, and 7% make suicide attempts. Over the past 5 years, adolescent visits to emergency departments for suicide-related reasons have tripled, and it's higher for girls. Rates of suicide vary by ethnicity among adolescents. The highest suicide rates are displayed by American Indians. Young white Americans are more suicide prone than African Americans or Hispanic Americans. Incidence rates, however, overall are closing among all groups. The elderly are the most likely to commit suicide and be successful. Contributory factors include illness, loss of close friends and relatives, loss of control over life, loss of social status, and ethnicity. Types of elder abuse that can create suicidal behavior include physical and sexual abuse, psychological abuse, neglect, abandonment, and financial or material exploitation. In terms of treating suicide, treatments after suicide attempts include medical care and appropriate follow-up with psychotherapy or drug therapy. We've talked about the psychodynamic therapies and drug therapies. There are also group and family therapies and cognitive behavioral therapy. A couple of those that are prominent today are mindfulness-based and dialectical behavior therapies. Goals of therapy are to keep the patient alive, reduce psychological pain, achieve a non-suicidal state of mind and a sense of hope, and develop better stress management skills. Suicide prevention involves crisis intervention, and so we have many types of programs, including suicide hotlines that are staffed by professionals or paraprofessionals. In terms of nationwide reporting, in Texas, you'll see we are a green state, which means that if we have a situation where a person has made a threat toward another individual or toward themselves, we have mandatory reporting if there's a threat toward self, and we have permissive reporting if there's threat toward another. Most people report in the state of Texas. Non-suicidal self-injury is a predictor of suicide, but not everybody who does this behavior is going to have suicidal behavior. As a clinician, we will most likely deal with ethical dilemmas about safety and duty to warn and protect around non-suicidal self-injury. It can be a way to transform emotional pain into physical pain. And we know that self-injury should be addressed in informed consent at the outset of therapy, because we may have to do mandatory reporting around it, and we want clients to understand that that could happen. Guidelines for assessing suicidal behavior are to take verbal warnings seriously, pay attention to previous attempts at suicide, identify those who are suffering from depression, feelings of hopelessness and helplessness, have impulsivity, have trouble problem solving, looking at interpersonal stressors of loss and separation, monitor severe anxiety and panic attacks, and look at any recent diagnoses of serious or terminal health conditions. We also want to see if there's a plan in place. Identify any substance abuse, be alert to behaviors such as giving away prized possessions, finalizing business affairs, and revising wills. Determine the history of psychiatric treatment, and determining if there are any lethal means that are available. We want to assess the client support system, ascertain whether there's been any suicide in the family, because both of those factors are leading to increased risk. If the client verbalizes suicidal ideation, we want to talk about whether he or she wants to die or wants the pain to end. And then written safety plans have become a common intervention in suicide prevention with high-risk clients. Safety plans can be used for self-injury as well, and they develop a context for exploring healthy ways for coping with stress. Finally, we want to make sure that we protect children, elderly, and dependent adults from harm. Mandatory reporting is designed to encourage reporting of any suspected cases of child, elder, or dependent adult abuse. If children, the elderly, or dependent adults disclose that they are being abused, the professional is required to report the situation under penalty of fines and imprisonment within 48 hours of knowledge or suspicion. This concludes the chapter on suicidality, and I will take up with the next chapter momentarily.